So we discussed 4 well cases. First, we start with the poll. A 65-year-old diabetic with 12-gram proteinuria and diabetic retinopathy presents to your clinic. What would be your next step? Consider kidney biopsy, start steroids, optimize RAS blockade and start SGLT2 inhibitor and evaluate for secondary causes. Stop RAS inhibitors because creatinine may rise. Please launch the poll, Yogita.
Yes, sir.
Please stop the poll and share the results. Majority have answered to optimize the RAS blockade and start SGLT2 inhibitor. Let's see the first case. The first case is a 65-year-old male who is diabetic for the last 25 years and 20 years, and he is having diabetic.
Slide સાથે પાડવાનો.
Huh? Slides have started moving, right?
Yes, sir.
Yes. So he presented to us with anasarca. Initial evaluation shown he has a creatinine of 1.7 and proteinuria of 12 gram per day. He was evaluated with, he has no history of any recent infections, no history of any complementary or alternative medication intake. His initial workup has shown, in addition to the renal dysfunction and proteinuria, he had negative ANA, no serum protein electrophoresis showing M-band or normal complements. He was initially started on telmisartan 40 milligram and diuretics. Later, when his edema subsided, his edema started decreasing. We have added SGLT2, slowly hiked up telmisartan to 80 milligram. He was followed up, and initially there was an increase in creatinine to 2.1. But we somehow convinced the patient to continue on these medications. And by 10 months, to our surprise, the patient proteinuria has came down to less than 1000 milligram per day. And his edema was completely resolved. We were initially planning to consider renal biopsy in this case, but based on this dramatic response, we have planned to continue the conservative management. So here comes the question: should every diabetic kidney disease patient undergo renal biopsy? We have to look for signatures of typical diabetic kidney disease, such as long-standing diabetes, presence of diabetic retinopathy, gradual EGFR decline, progressive albuminuria. All these things were there in our patient. And in this era of using ACARB, sometimes they might not have that significant progressive albuminuria initially. Then the red flags of non-diabetic kidney disease include sudden onset nephrotic syndrome, rapid decline in kidney function, absence of diabetic retinopathy, active urine sediments, short duration of diabetes, systemic clues such as low complement, positive autoimmune serology, monoclonal proteins, rash, arthritis, neuropathy, and significant weight loss. Now, almost all the trials of SGLT2 inhibitors has shown the benefit on the base of maximally tolerated ACE or ARB. How come this is? Because of the additive effects of both ACE and SGLT2. ACE-ARB, SGLT2, what it does is that it actually restores the tubuloglomerular feedback by increasing the sodium delivery to the macula densa. So there will be afferent arterial vasoconstriction. On top of that, when you give the AC and when there is ACE-ARB, which causes efferent arteriolar vasodilation, there is significant reduction in the intraglomerular pressure. That will lead to reduced hyperfiltration, and that in turn increases the podocyte health and reduces the inflammation and fibrosis. The major trials have shown consistent proteinuria reduction with the various SGLT2s, and there was a modest rise in serum creatinine. It is expected because there is some successful hemodynamic pressure offloading, and it predicts the long-term renal protection and should be evaluated alongside the albuminuria improvement. Now, when there is a massive nephrotic range proteinuria and diabetes, evaluate for atypical features or red flag. If there are any, proceed to kidney biopsy to rule out membranous nephropathy, FSGS, MCD, amyloidosis, IgA, or lupus. If it is a typical DKD with no red flags, we can maximize conservative therapy with ACARB, SGLT2 inhibitors, targeting blood pressure less than 120, glycemic optimization. And now we have one more drug in our armamentarium, that is fenrinon, that can be considered if persistent proteinuria is there. Now, the clinical pearls, nephrotic range proteinuria and diabetes should always prompt evaluation for non-diabetic kidney disease. Long-standing diabetes, diabetic retinopathy, and negative secondary workup strongly support diabetic kidney disease. SGLT2s can significantly reduce albuminuria with maximal benefit when combined with optimized ACE or ARB. A modest early rise in creatinine is expected and should be interpreted alongside the overall reduction in proteinuria and improvement in clinical status. Over to Suresh, sir.
Yeah. So Sonu, that was a very interesting case, but then it is a bit, it depends on the risk appetite of the nephrologist, because a lot of us would like to have a renal biopsy, especially for a massive proteinuria, before going in for this maximal ACE, ARB, SGLT2, or alongside you simultaneously work them up. But then there are a lot of patients who are afraid of renal biopsy and who don't want to proceed with it initially and who wants maximum medical management. So, Sribhushan Raju, sir, so what are the clinical features which will make you proceed with a kidney biopsy in such a patient?
As it was narrated already in the slides, but all these things are important and indications. Like if you have a present sudden onset of nephrotic syndrome, a presence of significant hematuria, and a rapidly progressive renal failure, absence of retinopathy, and also the recent onset of diabetes and very short duration. We have seen cases for the first time detected to have diabetes as well as the kidney dysfunction and proteinuria also simultaneously, all in one single patient. So these are the indication, but you don't have to go by all these things. There can be a retinopathy, an NPDR or something like that. But if rapid onset of nephrotic syndrome can be an indication. So a short duration of nephrotic syndrome, for example, he never had a proteinuria or he had a small amount of proteinuria last year detected. This year he has got a 10 to 12 grams. Definitely there's an indication. But I'm telling you, there are 50% chances that still he has a diabetic kidney disease only and a classical features of it. But you don't really require to give a steroid or something like that. But there are still possibilities of 50% that is a non-diabetic kidney disease. So indication for biopsy, you should be taken as a single, a case-by-case notion rather than giving a blanket statement. But here I feel personally that a 12 grams of proteinuria, which is a short duration of symptomatology. So probably you would require a kidney biopsy also. But nothing wrong in starting all these ACE inhibitor, ARB, these are all different. Ultimately, after doing the biopsy also, I might say that it is a requirement of ACE inhibitors, ARB and all.
Yes, sir. So, Dr. Sadish, coming to the $1,000,000 question. So, how much increase in serum creatinine after initiating RAS blockade or SGLT2 inhibitor would you consider acceptable?
I think very important point, because all of these drugs, whether you are starting RAS blockade, SGLT, fenrinon, or even the new one, GLP-1 agonist, all of them will cause a rise in creatinine initially. So the guidelines say 30%, but 30% is not an absolute value, and these are only guidelines. So it depends on how the patient is behaving. Supposing a patient comes, you have a creatinine of say 1.2 or 1.3, and the creatinine goes to 2.5. That will be a red flag. So high creatinine, that means something is wrong. But it rarely happens. So usually you get a 1.2 to 1.5, maybe a 30 or 40% rise. But an immediate rise without any other problem, say patient is having a very low blood pressure, that may cause a rise. Or the patient's uncontrolled blood pressure, that may also cause a rise. Or some other factors causing a rise. You're ruling out all that. There is only this one particular factor, this particular drug. In that case, even a 40%, 50% may be acceptable. But then you keep the patient on close follow-up. Supposing the rise is minimal, 1.2 to 1.4 or 1.5, then it's okay. You can always wait and watch. The other point is, when do you want to do this second creatinine? That's also a point. Usually I used to do after 2 weeks. That's the thing. So that will be a good time. But that in the UK and all that, they do only after 3 months after starting the drug. So what they say is that after 3 months, whatever the early rise will be there, that will all come out and then patient will be okay. But if there is an initial rise, you will miss that. So I think a 2-week interval is important for initial rise. A very abnormal rise will be a red flag, but a rise of even 30% or 40% is not a problem. You just follow up the patient and make sure it's not continuously rising.
Sir, do you do a renal artery stenosis screening routinely in such patients who would have a more than 30% rise, or?
No, if there is no severe hypertension, I don't usually screen, because if you look at it, supposing you do a screen and you find the renal artery, what are you going to do? So even if there is a renal artery stenosis, unless the treatment is only if there are some indications like uncontrolled hypertension or flash pulmonary edema or worsening renal function, without any other factors, only then you are going to do it. So it really doesn't matter. But if there is a abnormal rise, say that is it goes from 1.3 to 2 milligram, definitely I will be doing all this, evaluation for renal artery stenosis and all that. Because there you will find a chance for intervention.
Okay. Yeah. Sonu, I think we'll go to the second case.
Thank you, sir. Actually, this patient was not willing for biopsy. That's why we proceeded with this conservative management initially. But to our surprise, he came out well. Metabolic risk reduction with dapagliflozin is the second case. The audience poll, which of the following metabolic benefits of dapagliflozin is most consistently demonstrated in clinical trials? Yogita, please launch the poll. Weight reduction, reduction in serum uric acid, improvement in triglycerides, all of the above. Please close the poll and share the results. Yeah. Majority has stated, it is all of the above. Now let's move to the case. It is of a 45-year-old male, diabetic for the last 5 years, currently on metformin plus sulfonylurea. He presented with a BMI of 27, weight of 92 kg, labs shown hypertriglyceridemia, hyperuricemia, and transaminitis. AOS initially started, no. He was initially started on added dapagliflozin 10 milligram to his present medical regimen, and he was given a strict nutritional counseling with a structured exercise program, and he was followed up consistently, and within 3 months his weight has came down by 10 kg. His serum uric acid came down to normal levels, and his HbA1c has improved, triglycerides has improved, and liver enzymes has improved. Now, beyond glucose lowering, what are the broad metabolic benefits that we can expect from SGLT2 inhibitors? The trials have significantly shown that there is a weight reduction of around 2 to 4 kg on average, blood pressure reduction by 3 to 5 millimeters of mercury, HbA1c comes down to 0.5 to 1%, uric acid decreases by 0.6 to 1, MASLD, there is moderate improvement in enzymes and reduced visceral fat. Lipids, there is triglyceride reduction and improved insulin sensitivity. And SGLT2s provide simultaneous correction across multiple cardiometabolic risk factors, offering systemic cardiorenal protection far beyond simple glycemic control. When we deep dive into the mechanisms causing this, weight dynamics, urinary glucose loss is around 60 to 80 grams per day. It equates to a caloric deficit of 200 to 300 kilocalories, along with mild osmotic diuresis. While there are around 4 kg reduction in trials, this 10 kg weight loss is unlikely from the drug alone. The patient was highly motivated and he has followed a strict diet and exercise pattern to achieve this. And the lipid optimization, there is reduced hepatic de novo lipogenesis and increased fatty acid oxidation. It was driven by the improved insulin sensitivity and reduced visceral adiposity. So there will be reduction in triglycerides, HDL will increase, and the LDL cholesterol, there is no significant reduction in the LDL cholesterol by SGLT2 alone. Actually, what happens is that there is a slight increase in LDL. This is because of few factors such as hemo concentration, or there might be, but there is change in the LDL density. So the absolute LDL levels, even if it shows a mild increase, the atherogenic potentials improves significantly and the cardiovascular risk comes down. Now, the hyperuricemia resolution is because of the alteration in the urate transporters, because of the glycosuria, and there is decreased urate reabsorption leading to increased urinary urate excretion. And there is around 1 milligram per deciliter fall in uric acid, and improved metabolic profile also contributes to this uric acid improvement. In MASLD, there is a reduction in the hepatic fat accumulation, and combined with the weight loss and improved mitochondrial metabolism, it can aggressively lower hepatic inflammation. Around 3% of weight loss can actually improve hepatic inflammation. So the weight loss and other things combined can improve the liver health drastically. There will be reduction in the liver enzymes and improvement in the hepatic status on imaging and potential slowing of the fibrosis progression. Now, the ideal candidate for an SGLT2 might be a CKD with albuminuria, overweight or obesity, hypertension, heart failure or with high CV risk, hyperuricemia or history of gout, MASLD with elevated transaminases, and hypertriglyceridemia. In the complex metabolic patients, if we see, majority of these things are present in the individuals that is coming to us. At least 2 or 3 of this will be there in majority of the patients visiting our clinic. So the SGLT2 inhibitors can simultaneously target and treat multiple overlapping metabolic abnormalities. Now, the SGLT2 inhibitors provide metabolic benefits beyond glycemic control. When combined with lifestyle modification, they promote meaningful weight loss and improve insulin sensitivity. They lower serum uric acid and improve triglycerides, visceral adiposity, and MASLD. These pleiotropic effects complement their own proven cardiovascular and renal protection. Over to Suraj, sir.
Yeah. Coming to the discussion of the case number 2, again, it is one of the routine cases that we usually see in our OPD. So, Sribhushan sir, so which patient in your clinic is most likely to derive the greatest metabolic benefit from SGLT2 inhibitors? Please comment on your experience and share your
I must confess that I don't really follow up the triglycerides and lipid profile so frequently for all the patients. So, in fact, I was part and parcel of several of these international drug trials related to DAPA in diabetic CKD, that to obese CKD, and I did not analyze them separately. But triglycerides are okay, different. The uric acid, I really doubt. In uric acid, in fact, there was some elevation of the uric acid in some of my patients because of the dehydration and all. And I convinced them also that it's slightly because of dehydration. And compared to the previous report, there's a slight elevation of the uric acid, which is a routine investigation for all our patients. And then significant one is the weight reduction. And weight reduction, many people are comfortable, happy, and we could see a visibly visibly shrunken body of the people with these kind of drugs. And we in fact, they were complaining also that they lost good amount of weight and they are more comfortable, and they're complaining that how did they come down so easily also without much or major change in their dietary habits or the physical activity. So these are the things happen. So in fact, weight loss is an important phenomenon that imparts a lot of beneficial effects to the people with diabetes as far as the cardiometabolic syndrome is concerned and all. So I feel that of all the benefits, because triglycerides, maybe a good number of the people would have actually come down significantly as the weight and other things get controlled, especially the sugar control component of it attributes a lot of reduction in the triglycerides alone. So weight reduction is very, very important. According to me, most of these features are the people get benefited out of SGLT2 inhibitors.
Yeah. So the second question we'll direct to Dr. Arun Thomas. So Arun Thomas is the professor of nephrology at Believers Church Medical College and one of the champions for preventive nephrology. So question to Dr. Arun is, would these metabolic benefits influence your decision to prescribe an SGLT2 inhibitor even in a patient without CKD? So to put in short, can we use it as an aspirin for the kidneys?
Yes. Can you hear? Am I audible?
Yeah, Arun. Yeah, you're very much audible.
Yeah, yes, definitely. So already all the metabolic benefits Dr. Sonu has just briefed. So what I should tell in that case, the patient was on a sulfonylurea. The sulfonylurea should be the last line OHA that should be used in a patient with the metabolic syndrome and insulin resistance clinically, or the insulin resistance you can measure in the lab by